Good evening, everyone. Thanks to Rajiv sir and KOA for having me here. The topic we thought we'll have a discussion is on visual rehabilitation when the ocular surface is compromised. We'll dive direct into the cases. First one is a 67-year-old lady diagnosed rheumatoid arthritis on a systemic immunosuppressive, supposedly controlled systemic disease, has severe dry eye and has been on hourly lubricant for years. Her vision now was 636 in the right eye and 6 by 18 in the left eye. Had grade 1 sclerosis of the nucleus. Schirmer's was 1 and 3 millimeters and was advised cataract surgery. The case was referred to me because of a picture like this. As you can see in these pictures, there was diffuse punctate erosions of both eyes, right more than left. So obviously, the diagnosis is RA with secondary Sjogren's and severe dry eye disease with senile immature cataract. Now, with the picture like this, I'm sure most of us or all of us would agree that it's not ideal to go ahead with a cataract surgery. So unless and until we optimize the surface much better. So we went ahead at a small procedure, and this was how the eye was: quiet, clear cornea with moist looking surface in 3 days, and her vision improved to 6/9 in both eyes. The procedure that was done was nothing other than a small punctal cautery in both eyes. So the takeaway point here is that in dry eye disease, replacement of the tears with the tear substitute is just one aspect of management. A point or a treatment option which is considered much less or used very little is preservation of the tears, okay, which is otherwise, translates to occlusion of the puncta. So there are various different modalities for punctal occlusion. Most common is a temporary one with either collagen plugs, or if we can use this plain, simple 50 cat cut, which is available. You can cut it into small bits and push it into the punctal canaliculus to produce a temporary occlusion. But for me, the option is thermal cautery, which is a permanent mode of treatment in these cases. If the puncta is large and patulous, we may have to go in for a patch graft or even direct suture closure. Now, we come to a second case. This is a 19-year-old girl, just joined MBBS, have severe burning sensation, drop in vision in the right eye of 2 months duration. The history is of conjunctivitis severe in both eyes, right eye more than left 4 months back, after which she was having persistent problems in both eyes, especially in the right eye. Left eye was reasonably okay. On examination, her vision was 6/12 in the right eye and 6/6 in the left eye. Left eye examination was essentially normal. Right eye showed, as you can see in this picture, OP discharge. There was practically no tear marginal strip in the right eye. The surface was mildly congested. There was subconjunctival scarring, symblepharon, and cornea showed diffused, punctate epithelial erosions. Schirmer's was 0 in this eye, while in the left eye it was normal. So obviously from these features, we can say this is a cicatrizing conjunctival disease with a dry eye syndrome. But the question here is, what is causing the cicatrization? So another interesting finding in this case was, in the supratemporal quadrant, there was significant scarring and symblifera. So this gives us the reason for the dry eye. Scarring and obstruction of the ductules of the lacrimal gland is the reason for severe dryness in this. But then what is the cause for scarring? When we have cicatrizing disease, our first thought is about, OCP or mucous membrane pemphigoid. But in a 19-year-old, though it can happen, it is very rare. So it comes far down in our differential diagnosis. Here, the first DD will be a post-viral conjunctivitis dry eye disease, not a very common entity. Anyway, we started her on topical lubricants and topical steroids to control the inflammation. The inflammation reduced to some extent, but the corneal erosions were persisting and there was no improvement in vision. So we had to confirm the diagnosis. We went ahead with a conjunctival biopsy. And as I mentioned before, we did a punctal cautery. The biopsy came, negative for OCP or immunofluorescence. So the diagnosis is post-conjunctivitis, cicatrization of the conjunctiva with dry eye. And with punctal cautery, she had tremendous improvement. Her vision improved to 6/6 unaided. I can see a moist, quiet eye with glistening cornea, and there is a tear margin strip here. Though it is not from the tear production, it is from the drops which is produced, which is used, and the cornea is very clear. So again, a similar case, but probably a little older one. 71-year-old male referred to cornea clinic from glaucoma of persistent redness, discharge since December, 2020. Known glaucoma for past 16 years, has been, on various medications, but on irregular follow-up. That was last seen in our institute in 2017 when he was advised trabeculectomy for progressive glaucoma, but the patient was lost after this. His vision in 2017 was 6/9. Later, he presented in November 2020 with persistent redness, swelling in both eyes of long duration, discharge, and reduced vision. That was when, he was crossed to us. His vision at that time was 6/15 in right eye, and just hand movements in the left eye. Showed diffuse erythema and lid edema of both eyes. There was severe congestion in both eyes, and the clinical picture was almost same in either eyes. There was scarring in the right of cornea, in the right eye superior and inferior with superficial vascularization, and in the left eye, almost the temporal half of the cornea showed scarring with vascularization. The surface showed thickened lid margin, severe inflammation, subconjunctival scarring, as you can make out in these pictures, shortening of the fornices, the puncta were obliterated, and as I mentioned before, severe congestion. So obviously, again, from this clinical picture, we know it is a cicatrizing disease. These are the disc pictures showing advanced, glaucomatous atrophy in both eyes. And along with cicatrizing conjunctivitis, yes, open-angle glaucoma in both eyes. So 71-year-old with cicatrizing disease, severe inflammation, that first DD should be OCP or MMP. But in this case, the differential is a drug-induced cicatrizing conjunctivitis because of long-term anti-glaucoma medication use. So how to differentiate these two? The first step is to stop all the offending agents. The anti-glaucoma medications were stopped. He was started on topical oral medication to control IOP and was put on topical lubricants and mild topical steroids to control inflammation. Then, because of the age and the suspicion for OCP to be very high, we did a conjunctival biopsy, which was negative for OCP. So the final diagnosis here is drug-induced cicatrizing conjunctivitis. Now, how to proceed in this case? There is advanced disc damage. The IOP has to be really controlled well, and there is cicatrization of the conjunctiva, which means that a trabeculectomy is likely to fail. So went ahead and did an AGV for both eyes. The IOP got very well controlled, and on stopping the anti-glaucoma medication, both the eyes quietened down. The patient became very comfortable. After this, few months after AGV, he underwent cataract surgery in both eyes, with which his vision improved to 6/9 and 6/18. So the takeaway here is that always, consider surface problem as secondary. If the patient is already on drugs, think about a drug-induced cicatrization, especially on patients on anti-glaucoma medications who are on long-term treatment. And in case there is significant, persistent inflammation and progressive cicatrization on glaucoma medication, we have to take all steps to stop medications, any sort of medication on the surface as much as possible. Next case is a 27-year-old female who developed Stevens-Johnson's to ciprofloxacin injection, which was given for fever, was in ICU. We were called in for after a month of a stay in ICU. As you can see in these pictures, there were the blistering lesions on the skin, lip, oral mucosa were all on the healing phase. Both the eyes showed severe congestion. They were, the whole tarsal conjunctiva was denuded off, but corneal epithelial defect with, conjunctival staining positive, meaning conjunctival ulceration in both eyes. At this stage, uh, there is mounting evidence which shows that we have to, or the patient has to get an amniotic membrane to help in the healing process, which is what we did in both eyes, underwent amniotic membrane transplantation, and the eyes healed, whitened down, but there was significant lid margin scarring and keratinization, resulting in, severe surface changes on the cornea. Vision was just 6/60 in right eye and 6/12 in left eye. So both lids were showing, as you can see in this picture, lid margin keratinization, diffuse erosions in both cornea. And she used to get recurrent inflammations on and off, for which we used to put her on topical steroids. So here, the cause for recurrent inflammation and the epitheliopathy of the cornea is the lid margin keratinization, and it is like a sandpaper rubbing on the cornea. So this has to be addressed surgically, and she underwent a mucous membrane graft for the lid margin keratinization. The keratinized tissue was excised, mucosa was harvested from the lid, thinned out and sutured to the lid margin, and onto the tarsal surface it is glued with fibrin glue. This was done for all 4 lids, and finally the eye whitened down, cornea cleared, and her vision improved to 6/6/9 in both eyes, and which was maintained the last 5 years till her last follow-up. So this is a similar case of Stevens-Johnson. If you can see the asymmetry in between the eyes, the right eye is quiet, left eye showing significant inflammation, and there is severe keratinization of the left eye lower lid. This was actually nearly 12 years after the acute event of the Stevens-Johnson. The eye survived this long because of the significant, moisture, or there was still tearing present. And right eye, the lids were normal, left eye only the lower lid was keratinized. So he underwent MMG and the eye quietened down. This is another case which underwent MMG, happened when I was in Sankarnath earlier. See how the corneal lustreless keratinized surface with counter fingers half meters, and few years after the mucous membrane grafting, the cornea is cleared up and the vision improved to 6/18. And the keratinized patch on the cornea has reduced significantly. So, in cases where there is inflammation, it is important to distinguish what is causing the inflammation here. Is it a mechanical or is it an immune-mediated inflammation? Mechanical causes like keratinization or lid malposition has to be addressed surgically, and immune-mediated conditions have to be addressed with immunosuppressants or steroids. Now, this is another case of Stevens-Johnson, but as you can see here in this picture, the lid margin keratinization has been addressed with mucous membrane graft, but there is still significant bulbar surface and corneal changes, keratinization, haze, vascularization, and the vision is only counting fingers 2 meters. So how to improve the vision? A similar case, but then post chemical injury, counting fingers, vision only. Central cornea is reasonably clear, but then peripheral vascularization, scarring of the cornea. So what can be done to improve these cases? The obvious answer is surgical interventions, but then especially in Stevens-Johnson, any surgery for corneal problem has got very, very poor outcome. So surgical option as much as possible should be the last option in these cases. One very simple, underutilized and unrecognized treatment option in conditions like these is scleral contact lenses. In this Stevens-Johnson cases, with just fitting a proper scleral contact lens improved the vision to 6/24. And in the chemical injury guy, it improved to 6/12, avoiding the need for any further surgeries. So always keep in mind that, the scleral contact lens, about scleral contact lens in these kind of cases. Now, coming to next case, the 52-year-old lady, again, SJS to said prophylaxis, was in ICU for 3 months, came to me with six vision in both eyes at 3 months, with the total defect of the cornea and conjunctiva, underwent multiple surgical procedures over the period of 1.5 to 2 years in both eyes, with no success or response to treatment. And finally, this was how the eyes ended up with total surface damage, cascade, keratinized surface, and vision was just perception of light. So what is the option for visual rehabilitation in these cases? As you guess, the only option is a prosthetic devices, because any sort of transplant of cornea or stem cell in these cases will result in failure. So of all the keratoprostheses available for cases like these, the only one that has shown to be of excellent results or outcome is modified osteoodontokeratoprosthesis. So this is a procedure which is done in 3 stages spread over 6 to 9 months. 1A, which is essentially a preparatory stage, we remove the the cornea if cornea is thin, remove the iris in toto, then do a in ICCE, and then the most important step, examine the disc and macula and retina, anterior vitrectomy, close it with the cornea and close the surface and leave it like that for a month. After a month, we go ahead to the stage 1B, which is harvesting the mucosa from the cheek, and it is trimmed and sutured down to the ocular surface. So this is from the cheek. The surface is opened again, all recti intact, and the mucosa is kept on the surface and is sutured to the ocular surface. So, and at the same sitting, we proceed with 1C, which is the preparation of the ODAL or osteodental acrylic lamina. The canine tooth with the the root and the bone around is cut and removed. The 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 enamel is then removed or cut and thrown off. The root is with the surrounding bone is used to prepare the lamina. It is finely thin, ground and thin to make a 3 mm disc. The center of the dentine is then drilled to create a hole into which the optic cylinder is fixed, and it is then implanted in the submucoid pouch in the orbital area and left there for 2 to 3 months to get a good healthy fibrovascular capsule. At 2 to 3 months, the pouch from the pouch, the ODAL is removed. The anterior and the posterior surface is cleaned to expose the cylinder. The mucosa is reflected. The ODAL is then fixed onto the surface. Central corneal opening made. One end of the optic cylinder is pushed through that, and then it is fixed onto the surface. The mucosa is covered and sutured. Center is opened, and the anterior surface of the optic cylinder is exteriorized. So this ends the procedure, and proud to say that at Giridhara Institute, we did our first modified osteodentokeratoprosthesis completed in November 22, and probably we are the 15th or 16th center in the world to offer such a procedure. So this lady at 1 month has 636, has started cooking and is happy. Now, another similar case, 67-year-old Stephen Johnson, again, multiple procedures done, finally ended up with tectonic and tarsography with just PL vision, but elderly with COPD and very unhealthy tooth. So not a candidate fit for multiple long GAs. So we ruled out option of modified osteodontokeratoprosthesis in these cases and decided to go ahead with Boston type 2 keratoprosthesis. The patient underwent Boston type 2, which involves, again, dissecting the surface. Here, the cornea was thin and ectatic, had to do a large graft. But along with that, in Boston type 2, it is mandatory to do an Hermann glaucoma valve through the pars plana, a total vitrectomy. Now, Why Ahmed glaucoma valve is because the incidence of glaucoma after Boston type 2 keratosis is very high. So all cases undergo AGV. Here a cornea is fixed and then the center is opened, temporary keratosis is fixed, and the total reflective is done. Then the keratosis is assembled to the surface. Now, this is the anterior stem protruding from the anterior plate. The valve is, implantation is complete, ports closed. The lid margin is excised and the total tarsorrhaphy is done, and anterior end of the processes is, exteriorized in between the tarsorrhaphy. This is the patient at 1 month, 6/9 vision, and the patient is happy. Now, the obvious question will be why, we should do a procedure in like MOKP when type 2 exists. The reason is the long-term retention and the, better outcome or the possibility of having less complications is much, much more with MOKP compared to Boston keratoprosthesis. So the first option in such cases is always MOKP. And only if MOKP is not suitable, we think of other options. So in short, when we are faced with a patient with compromised ocular surface, the first thing to look at is the dry eye, address it, then look for inflammation, identify the cause for inflammation. If it is mechanical, surgical intervention, immune mediated, they need steroids and immunomodulators. On treatment aspect, always keep the option of scleral contact lens, because many cases a simple scleral contact lens is all that suffices. Once the surface failure has set in, it has to be addressed in a stepwise manner. Reconstruct the lids, followed by fornix conjunctiva, and then the limbus and corneal epithelium. In end-stage disease with limbal stem cell deficiency, in unilateral cases, if adnexa is normal and the eye is moist, we can think about stem cell transplant from the other eye. If in unilateral severe dry eye with a normal contralateral eye, it is best left alone, because the surgical options are all complicated with lots of problems. In bilateral stem cell deficiency with a moist and normal adnexa, we can think about allo stem cell graft, but then requires systemic immunosuppressive, so not a great option in our setup. We can think about a Boston type 1 keratoprosthesis or OK-Pro or OK-Pro. And then in bilateral severe dry eye, like in the last cases, the first option will be a modified osteodermal keratoprosthesis or type 2 Boston keratoprosthesis. Once again, thank you for the kind invite to be here with you all today. Thanks again.